You know that moment maybe you let out a really big laugh or a sudden cough just sort of escapes?
Yeah, and for quite a few people, right then there's that unexpected, well, leakage.
Exactly. And that specific thing happening because of something physical, increasing pressure inside you, that's our topic, stress incontinence.
Mm-hmm. And today we're doing something a bit different. We're diving straight into your revision notes on this.
That's right. These notes you've got, they define it really clearly. Involuntary urine leakage during activities that increase that intra-abdominal pressure.
Like coughing, sneezing, laughing, maybe exercising, lifting something heavy.
And the notes point out it's much more common in women and tied strongly to a weakened pelvic floor or urethral sphincter.
That definition is absolutely central. The timing leakage happening with that pressure spike, that's the key.
Right. So consider this session like a guided tour through these specific notes you have. Our goal is to unpack everything they cover.
Definition, causes, how it actually works mechanically, what else it might look like.
Yeah, who gets it, the symptoms, how doctors investigate it, the management options, prognosis, complications, the works.
We're basically pulling out the high-yield stuff for you, trying to make sense of the structure of these notes in a way that hopefully sticks.
Helping you navigate this for revision, make it a bit more manageable.
Exactly.
Okay, let's start by really nailing down that definition again.
Okay, so based on your notes, stress incontinence is all about leakage happening with that increased abdominal pressure. It's not about a sudden urge.
No, it's mechanical, isn't it?
Yeah.
Happening when that internal pressure goes up.
Precisely. And the root cause, as the notes state, is some kind of issue with the support structures down there.
Weakness or damage to the pelvic floor muscles and the urethral sphincter.
That weakness is the common factor. So let's unpack the why and the who. Etiology and risk factors in your notes, they're very closely linked.
The main cause listed is that weakening or damage we just mentioned. Pelvic floor muscles, urethral sphincter.
Right. And the risk factors, well, they're basically the things that cause that weakening or damage. Being female is, number one, it's way more common in women.
Which makes sense, thinking about anatomy and, life events. Pregnancy and childbirth are big ones listed.
Especially multiple vaginal deliveries, or if forceps were used. That's direct physical stress on the pelvic floor.
Big time. Then there's menopause, hormonal changes, often linked to aging in the notes as well.
Yeah, the drop in estrogen after menopause can affect tissue strength and elasticity in that whole area. Makes things less supportive.
Obesity is on the list too.
Right.
And chronic coughing, which is interesting.
So?
Well, the leakage is triggered by pressure, right? So if you're constantly coughing, you're constantly putting that pressure on a potentially weak spot.
Right, like hitting the same spot over and over. It makes sense it would give way eventually. Pelvic surgery or trauma, those are pretty direct causes too.
Yeah, potential direct damage to muscles or nerves. And the notes mention family history, so maybe a genetic link or shared risks.
Could be either or both. So you see, it's this mix of anatomy, life events, stressing the system, chronic things, adding strain, all leading back to that weakened support.
Okay, so that's the why. How does it actually happen? The mechanics, the pathophysiology. This is where it gets interesting.
It really is. The notes explain it as basically inadequate support from those pelvic floor muscles and the sphincter when you do something that increases pressure.
So normally, everything should tighten up automatically to keep the door shut, right?
Exactly. The pressure inside the urethra should stay higher than the pressure inside the bladder when you cough or jump.
But with stress incontinence, that reflex, that support, it just isn't enough.
Correct. The notes mention this leads to structural changes. The bladder neck might drop a bit, or the urethra isn't held as firmly,
Resulting in lower pressure holding the urethra closed.
Precisely. So the door is weaker, maybe doesn't close fully, and when that abdominal pressure spikes from a cough, a sneeze, a jump, it pushes the bladder pressure higher than the weakened urethral closure pressure.
And leap.
That's it. A failure of the continence mechanism to cope with that sudden pressure rise.
Okay, so if someone has involuntary leakage, it's not always stress incontinence. What else do the notes suggest under differential diagnosis?
Good point. The notes list three main alternatives. First, urge incontinence. They explicitly link this to an overactive bladder.
Okay, so the key difference there is?
A sudden, intense urge to wee right before the leak. It's not necessarily linked to a physical activity like coughing. It's more about the bladder muscle contracting when it shouldn't.
Got it. Urge is the bladder being twitchy, stress is the support failing under pressure.
Nicely put. Second is overflow incontinence. The notes describe this as leakage when the bladder's just too full because it doesn't empty properly.
So like a constant dribble or unexpected leakage because the tank is overflowing.
Kind of, yeah, the bladder's overdistended. And third, there's mixed incontinence.
Which sounds like exactly what it is.
It is a combination. The notes say these people have symptoms of both stress and urge incontinence, leakage with activity, and those sudden urges.
So it's not always clear-cut. Important to know these differences, though, because the treatment will be different, right?
Absolutely crucial. Different causes need different approaches.
Right. Let's talk numbers, epidemiology. How common is this, particularly in the UK context mentioned in the notes?
The notes are clear. It's common, especially in women. The figure given is pretty striking. Around 20 to 30% of women in the UK experience some degree of it.
Wow, 20 to 30%. That's potentially nearly 1 in 3 women? That's huge.
It really puts it into perspective. And matching the risk factors we talked about, the notes say prevalence increases with age, and it's more common after vaginal births. The numbers back up the causes.
So what does it actually look like for the patient? Clinical presentation. What are the key symptoms in the notes?
The absolute main symptom, the defining one, is that leakage of urine during activities that raise intra-abdominal pressure. The coughing, sneezing, laughing, exercise we keep mentioning.
The predictable pattern.
Exactly. Predictable leakage linked to physical exertion or action.
Are there other symptoms listed?
Yes, the notes do mention things like a frequent urge to urinate. Though remember, for pure stress incontinence, the leak itself isn't triggered by the urge.
Right, the trigger is the physical pressure.
Correct. Also, maybe difficulty emptying the bladder completely or some mild discomfort down below. But the timing of the leakage with activity is the classic sign.
And I guess the severity can vary a lot.
Hugely. From, just a tiny dribble sometimes to significant leakage that really impacts someone's life, stops them doing things they enjoy.
So how is it typically diagnosed, clinically speaking, based on these notes?
Well, clinically, it often starts with listening to the patient's story, their history. The notes say they usually report that predictable, frequent loss of a small amount of urine during physical activity.
And crucially,
Without that strong urge right beforehand, it's that clear link to the rise in abdominal pressure.
the history sounds really key then.
It is. Then the notes mention a comprehensive physical exam, neurological, vaginal, rectal exam.
And what are they looking for there?
Partly general health, but specifically looking for things like pelvic organ prolapse. Your notes mention this where organs descend, prolapse can worsen incontinence, and it's also listed later as a potential complication.
Ah, okay. So checking for related issues. History and exam are the first clinical steps.
Yeah.
What about more formal investigations? What do the notes detail?
Right, investigations. Several are listed to confirm things, check severity, rule out other causes. First up, the basics we just covered. Detailed history, physical exam.
And urinalysis is mentioned prominently.
Absolutely essential. The notes say it's to rule out things like a UTI, a urinary tract infection. Infection can cause or worsen symptoms, so you need to check for that first.
Makes sense. Rule out the simple stuff.
Then the notes mention more specialized tests, urodynamic studies and imaging like ultrasound or maybe cystoscopy. These aren't always needed, but can assess how the bladder and urethra are functioning, check the anatomy.
Urodynamics.
Okay,
That's
got it.
measuring pressures and flows, right?
Yes, things like bladder capacity, pressures during filling and emptying, and really relevant for stress incontinence, measuring that urethral closure pressure. It helps see the mechanics.
So you can quantify the problem.
Pretty much. The notes also list some additional diagnostic tests.
Okay, let's run through those. Urine dipsticks and cultures again.
Yes, just reinforcing that need to check for infection. Then creatinine and BUN are listed. Those are kidney function tests. Important if there is a concern the bladder isn't emptying well and backing up, perhaps?
Less direct for stress incontinence itself, but part of the bigger picture. What about a pad test?
That's a very practical one mentioned. Basically, you wear a pre-weighed absorbent pad, do some activities that might cause leakage, then weigh the pad again.
Or actually measure how much is leaking.
Exactly. Quantifies the severity. Urodynamic studies popped up again, specifically mentioning measuring bladder and urethral closure pressures confirms their role. And urinary stress tests.
What are they?
The notes describe demonstrating leakage during activities that raise abdominal pressure. So asking the patient to cough or bear down during the exam to see if leakage happens right then and there.
A direct clinical confirmation.
Yes. And finally, cystoscopy.
That's the camera into the bladder.
Right. The notes say this is mainly to rule out rarer things like fistulas, abnormal connections, or bladder tumors, which could potentially mimic incontinence symptoms.
Okay, that's a really thorough workup pathway outlined in the notes. So once it's diagnosed, what can be done? Management.
The notes lay out the UK approaches, broadly split into conservative and surgical. The choice really depends on how bad the symptoms are, the impact on quality of life, and what the patient prefers.
Let's start with conservative management. Sounds like the first step.
Typically, yes. Lifestyle changes are big here. Weight management, if needed, can reduce that constant pressure on the pelvic floor. And pelvic floor exercises Kegels.
Actively strengthening those muscles that are weak.
Exactly. Targeting the root cause. Bladder training is also listed under conservative, though maybe more for urge. And using pads or devices to manage the leakage directly.
Okay. What if those aren't enough? Is there prescribing management medications?
Yes, the notes mention pharmacological options if lifestyle changes and exercises don't cut it. Things like alpha-adrenergic agonists are listed, which might help tighten the urethra a bit.
Okay.
Topical estrogen is also mentioned, specifically for postmenopausal women. If there's vaginal atrophy, the estrogen helps improve tissue health down there. And sometimes tricyclic antidepressants are considered.
Interesting range of medications. Then there's non-prescribing management listed separately too, though it seems to overlap a bit.
It does. Lifestyle mods again, weight loss, cutting down caffeine, stopping smoking to reduce coughing. Behavioral therapy is here too, like pelvic floor exercises again, sometimes using vaginal weights for extra resistance.
Like resistance training for the pelvic floor.
Kinda, yeah. And then surgical options are mentioned as more of a last resort.
Right. If nothing else works or isn't right for the patient, what's the goal of surgery?
To enhance urethral resistance or support the bladder neck better. The notes mention two main types. A mid-urethral sling, like a little hammock supporting the urethra or surgically fixing the urethra, or bladder neck to nubile tissues to lift and stabilize them.
Physically providing that missing support.
That's the idea. And finally, the notes list additional methods used alongside other treatments.
Like absorbent pads, which we mentioned. Also catheterization and vaginal pessaries.
Yeah, pads manage symptoms. Catheterization is usually for more complex cases, perhaps difficulty emptying. Vaginal pessaries are devices put inside the vagina to provide internal support to the bladder neck and urethra, can be quite effective for some.
Right. Quite a toolbox of management options there. What about the long term? Prognosis. What do the notes say?
Well, it depends. Depends on symptom severity and how well treatment works. But the good news, according to the notes, is that many people do get improvement in symptoms and quality of life.
So treatment often helps significantly. It's not hopeless.
Definitely not. But the notes do add that long-term management might be needed. It's not always a cure and forget situation. Might need ongoing effort to maintain continence.
Okay. And are there potential complications? Issues linked to the condition itself?
Yes. The notes list a few important ones. A really big one is the impact on quality of life. This isn't just physical, it's the embarrassment, avoiding social situations, feeling less confident.
That emotional and social toll really highlights why effective management is so important.
Absolutely. Then there's an increased risk of UTIs and skin irritation from the dampness.
Makes sense, unfortunately.
And lastly, an association with pelvic organ prolapse is noted. We touched on this, the organs descending. Prolapse can occur alongside stress incontinence, and the notes say it can make urinary symptoms worse.
So they can be related problems influencing each other.
Often are, yes.
Okay. So we've really walked through the whole structure of these revision notes. Definition, causes, mechanism, diagnosis, management, outlook, complications. Your notes didn't seem to have specific mnemonics or example questions, though.
No, they didn't. But honestly, the way we've just gone through it, that structure is a memory aid.
I mean,
By following that logical flow definition, why it happens, how you find it, what you do about it, you build a mental map. It's about understanding the story of stress incontinence, not just isolated facts.
connecting the dots, like seeing how the cause, the weakness, and the mechanism pressure beating closure directly lead to the management goals, strengthen the muscles, or add support.
Exactly. Thinking through those connections, that why leads to what, makes it stick much better than just trying to memorize lists. Use this structured walkthrough as your revision framework.
Right. So we took your notes on stress incontinence, went section by section. Hopefully this deep dive has made the key points clear, made the topic feel a bit more manageable for your revision.
We've tried to pull out the essential info from each part of the material you provided.
And if you are looking for more resources for revision, specifically for the MSRA perhaps, You can check out pastandcr.com.
And also freemsorry.com.
Good plugs.
Yeah.
Okay, one final thought to leave you with.
Yeah.
We talked about the complications, especially that big impact on quality of life, the embarrassment, the isolation. Think about how that really underlines the need for healthcare professionals to proactively ask about these symptoms. Patients might not bring it up because it feels awkward or shameful.
That's a really important point. It pushes us to see that managing incontinence isn't just about stopping leaks. It's about helping people regain confidence, dignity, and the freedom to live their lives fully.
Well said. Thanks for joining us for this deep dive into your notes.